Welcome back from morning tea to the second session today. For those who don't know me, my name's Peter Merrilees. I'm lucky enough to be a member of the Point of Care Committee, and I'd like to introduce our first speaker this session. We've all heard from Roger just before the break, and he's back to interest us and hopefully amuse us again. So please, Roger, come on up. Thank you.
I feel a little bit embarrassed to be here again, but you had a break, so you can't complain. And because we know each other so well right now, I would like to make a picture to show to Holland later. But of course you need to be very enthusiastic, and so that's what I want to see in this picture, please. Thank you. I need some proof. My boss was not very happy that I decided to go to Australia, but now he will be, I'm sure of that. Okay, let's go to the second talk, if it works. Well, it remains dark, complete darkness. This helps. Maybe. All right, a little bit. The Dutch model or Netherlands model, it doesn't exist actually, but I can show you at least an example of how we try to take care of point of care testing. Again, you're the model country, I would say, if it comes to the added value of point of care testing. But still, we did some work as well. My title could be also point of care testing in primary care, labs on the move. And this is not liked by a lot of lab personnel, but I work in one of those labs. And I will try to send out this message. But to start, again, we talk about patients. I show you one of my own patients who experienced point of care testing some time ago, and this is what he thought of it. Hopefully.
En toen heeft hij met het apparaatje wat hij heeft, het is een wonderlijk apparaatje, hij prikt je in je vinger. En duwt het in ik noem het dan maar even, een apparaatje. En na 3 minuten weet hij of jij een longontsteking hebt. Of iets anders. Nou, ik stond zo te kijken natuurlijk, hè.
I'm not going to talk about CRP testing, but this patient was quite enthusiastic and made the doctor grow, you know. Sometimes you need a little success, and this is the magic which could be done with point of care testing. All right, so the Dutch situation, you recognize this problem, this challenge. There's more hospital care being how do you call it, transferred to primary care and sometimes to patients at home. So there's a lot of volume coming to our GPs, more complexity. There's not much more time or financial support. So as a result of this, I'm sure diagnostic testing will be more and more important in the coming years, despite all those efforts to reduce unnecessary diagnostic testing. Our system really relies on primary care, so the doctors, the GPs have a very strong position, a very strong set of 100 guidelines, which are followed quite regularly, not in detail, but there are a lot of studies done that show that GPs adhere to those guidelines, and actually hospital doctors use those primary care guidelines as well. And there we have this other triangle, that is the situation. We have private health insurance companies who buy care from all kinds of institutions like diagnostic centers. We have the patient and the care professional. The GPs in general practice, they deliver services for listed patients, so it's really family medicine. That means they get paid, how do you call it? Per capita, is that English? Yeah. But also get a little fee for every consultation the patient does. In this way, there are no diagnostic perverse incentives to do a lot of testing, so which is good, I would say. This is different in Switzerland, for example. So this is the basic situation. I forgot something. Well, those health insurance companies, it's called a regulated healthcare market. That means if, as a diagnostic center, you earn too much, you could cut down the year after that. If you earn too little, you're just broken. So that means it's very hard to call it a health market, and happily it's not a free health market maybe, but I would like to see that healthcare is not a market at all. But that's my personal opinion. Let's see. We saw in the UK at least that the last 15 years there was a 3 times rise in doing lab tests. And like I said, there is some competition going on in Holland. It's between those primary care diagnostic centers and the hospital labs, which is good if it comes to implementation of point-of-care testing, because when I started using a diagnostic center to implement the point-of-care test, the hospital labs were looking at us and they thought, okay, they are gaining some, they providing service for their clients and for patients. Let's do the same. So now many labs implement point-of-care testing and take control of that. So if it comes to quality assurance programs. So after introducing CRP, the doctors get more and more enthusiastic and they start asking me, what's next? What else do you have? We want to start using it as well. And this is just a graph to show you, and if you look at the green, is what they say they like to get done in their own office. And this is from 5 years ago. And the red is what they already have. And you could say that CRP is the first, POCT of the new generation. And of course there's the glucose testing and just urine stick and the pregnancy testing. And in Holland you can see that D-dimer is very popular. It's not popular in Australia, it seems. Not yet. You see that also in this graph, because it was a part of a European study, and including, I think, Australia and the United States. Oh, not, yeah. And there you see that pulmonary embolism and deep venous thrombosis is popular in most countries, but not in Australia. We'll go back to that. First, a question for you, and there's only one answer possible. Can you tell me what is the most famous POCT device in the world right now? Glucose? And a particular device maybe, or just glucose testing? Okay, any other wild guesses? You're getting too serious. I'm not that serious, you know. This is the one. Do you know what it is? So that remains a secret again. I had to remind of that because when I was looking from my bed to the telly, I will always look in hotels if I can see a product from my own town, Eindhoven, the Netherlands, which is Philips. It's a Philips base. And happily again in this hotel today I saw this Philips monitor. And it reminded me of a large project which was going on point-of-care testing by Philips. I was very enthusiastic. In my hometown, they were building the all-in-one device, which I need for 10 years already. And just before the release, they stopped the whole project. They sent 200 people home. And I didn't know why, actually. It's now bought by Siemens. So I'm not sure if the Siemens is here already, but I will talk to them. Because I'm afraid it's going to go right into the fridge and doesn't come out anymore for a while. So you still don't know what the device is on the right side, but maybe you know when you see this. So if you go back, this is the Edison, the famous Edison. It's not a coincidence that it's called Edison, because Edison was an inventor who invented not so much, but he bought all the good ideas and then showed that he was the one. And well, if it comes to Barbara Holmes, there are a lot of similarities. I think not the way she wanted to be, but still, it was amazing to see this documentary about her. All things went wrong, you could say. It was fake it till you make it, but she didn't make it at all. But I use it in my presentations because she somehow got the investments of $9 billion without doing anything, just show us her face and her Steve Jobs appearance. She reduced her voice to be more confident for the investors, and it all worked out well. So that means that she did something well. And in her hand she has this small container to take just a few drops of blood. And her story is that she would do 200 tests with those 2 drops of blood. Again, she didn't make it, but it means for me that the public is ready for something new than venous blood sampling. Okay, this is the role patients should have, not care based on silos, but just in the center. And this is the principle I would like to work on. Again, with this slide I already showed. And there's a lot of reason to believe that POCT is the next thing, because the technology is there. Microfluidics, I think it's very powerful. And of course, there will be iPhones doing regular urine testing. I tested one device, which was, well, it looked very solid. We tested the tap water, and the tap water had a chronic urinary tract infection. I'm not sure why, but happily, this company also had the therapy you could buy. But still, this is a bad example. There will be good examples. So I think a lot of our diagnostics is democratizing. It's going to the homes. People will do it themselves. Certainly, if we have this perfect all-in-one test, and this is the actual situation. So you can understand my frustration a little bit now. My appeal is to the diagnostic industry, something like this, doing what patient needs next. I see a lot of slogans, but I haven't seen the ultimate solution yet. So please, if you have one, come to me. Because there are many reasons to do point-of-care testing, and basically in the Netherlands, because we don't have those geographical challenges, we still need this test done for acute care situations, because then a lab test is still too slow. There's also a service reason why I'm interested in point-of-care testing. Why should a patient take off from his work 2 times a week to go to the doctor and just to say all the results were good? You can go home, for example. Well, the lack of facilities is not the case in the Netherlands in most part. And it's also by raising the quality of care. I think I showed you an example in my previous talk. And I'd like to evaluate on quadruple aim, so not only on better healthcare outcomes, also in the improvement of patient experience or the perceived care. Of course, it has to do with healthcare costs, but also about taking care of our doctors. You know, they have a hard time, it's busy. And you see that most evaluations, if it comes to devices, are on the first one, the performance, analytical performance of tests, and not so many on the added value in daily care. So we have still some work to do. And with all those tests, it is very important to show, otherwise you get this medicalization effects, that we see the right context in where we do our tests. You know, this is very important. So we should educate our doctors. So I would like to see, and our diagnostic center, our board of directors was shocked when I showed it, but I think they tend to believe me that we don't have a central lab anymore. I think it's in Dutch, I'm sorry. But you see this is called the Diagnostic Knowledge Center. This should be in the center. Well, yes, we have a lab somewhere and some other service points where we have some labs in a prison or whatever, nursery home. And of course at the GP's office. And again, around the GP's office, there will be the patients who are using INR, for example. INR self-testing is quite popular in the Netherlands. So many reasons to believe we need this hub and spokes model to be completed. What we see, and this is a little bit the shock of the clinical chemists in our lab, is that the number of CRP tests rise, not because the doctors are doing more tests, but just because more doctors are doing tests. On average, to be reassured, it's only twice a week that a GP does a CRP test. So we should be afraid of over testing, not too much. But what you see is that the level, these are the winters, of course. You see that it already reaches the volume of the central lab tests. So you can imagine if I say, well, now let's go for lipids and leukocytes, that some people think, I'm not sure if this is a good thing to do. But I think if you, as a clinical chemist, feel responsible for what you do, whatever it is, where it is, a central lab or at the GP's office, you're still on the job. So I don't have to explain to you what point of care testing is, but it's just to stress that I think it's the whole process which is point of care testing. Is not a rapid test, and I have to explain that to many doctors. And it's also a unique moment, and it's already addressed before, that you support your clinical decision-making process when the patient is still there. So this is the unique characteristics. So this is practice. When we started introducing some tests, this is a quick read go, just next to the heater. And this is the quality assurance program. So when I send out the analyst and I said, the GPs will be fine, they came back crying. They said, this is not gonna work. But I have to say, within 2 months' time, it's really easy to educate GPs' offices. But they're just not used to quality assurance and lab testing. But they can really do a great job, because that's what we showed afterwards. We also have these kind of challenges, of course. This is also the patient who needs to be told that, well, diagnostic testing is a delicate process. And I often ask the question, are oranges dangerous or healthy? And then it's a hard question, but the answer is, of course, dangerous. That's how it all started in the Netherlands, when a nurse ate an orange, took the glucose of a patient in the hospital, and the glucose was very high, and then insulin was used and the patient died. And that's the moment where the Dutch Inspection of Healthcare said, okay, from now on, there's no longer a possibility that you have a point of care test without a quality assurance program. Strangely enough, that's true for now, since 2008, but only for hospitals. So GPs still have all freedom to do whatever they want, to just buy a test from internet and start using it on patients. Luckily, there were some reports on that the hygiene in GP's office is not that great, and that we should do better in taking care of quality assurance. And I started to make a guideline and involved all those groups, like clinical chemists, the microbiologists, the lab world, and to collaborate with our own Dutch College of GPs. And we made this Dutch guidelines, a very boring guideline, but still necessary to show doctors, okay, you need to do it because it has reason to work on quality assurance. Okay, so there are many initiatives and in the whole countries if it comes to point of care testing. I think there are a lot of delegate groups which could use some way of point of care testing, and I started to use, well, these instruments, or I'm ready to start using it. These are all those navigation systems you saw on your car. Too many, but still we're just going to do it basically with a central point of care testing team, which is delivering all those services. And in the middle, we use the MSACC software from Abbott, which they say at least can, it's an open system, so they can connect all those different devices. What I found out is it depends on when you need it, so sometimes it takes a while before you get your device connected to the system, so there's work to do, because it's I think it's not possible. I'm working on a D-dimer test, and I would like to, well, our GPs ask me, can I use it next month? And I say, well, you're the first in 2021 to be connected on the MSACC system, so maybe I should have a talk with Abbott. All right, all kinds of ways to control. That's what we do already. So we have we know every operator who's dealing with a point of care test in our primary care centers. We have around 350 GP centers who are using our POCT service. So we know all the operators, and we see who's logging in and who's making which mistakes, so that we can react on it, whether it be a technical problem or an operator problem. So this is all already in place. And this is the main model. Well, like always, this is GP and a patient who decide, well, maybe we should need a test because I don't know what's going on. And then there's a barcode produced, which is read into the POCT device and sent automatically to the MSACC system, which is controlled at our diagnostic center. Then the patient drops a drop of blood, and the test result is sent to the MSACC system again. There the patient information and the test result come together and can be controlled. So here's the quality assurance program going on, and you see the red flags when we need to react, when there's an error. And after a validation, it's it's on our laboratory information system and sent back to the GP information system. And next to that, we have this reimbursement thing. So for every patient, we reimburse at the health insurance company, and with this money, we can maintain the system. So it's, well, up till now, we pay a little more than we gain. But if we extend our service, it will be equal, I would say. So in this way, we can implement POCT in the Netherlands if all the other labs are doing the same job, which is not the case at the moment. But I think we are trying to make the perfect example. And the last part is, there's still a lot of research to do. Not many things are investigated well. So these things that we've been doing, for example, we compared all kinds of automatic urine analysis and analyzers. And the next thing is, with one of them, we went into the practice and thought, okay, does it have value when you compare it with the simple eye of the practice nurse who does this job for many years already? And it was a little bit better, and so we were happy, because then we say, okay, then we got reason to introduce it in daily care, which is happening right now. And it's helpful when you can even stick 8 urine sticks at the same time, particularly on a Monday morning. So this was asked by our practice nurses. So that's what we're trying to do. Okay. And then again, D-dimer, there was a kind of pregnancy test before. A D-dimer test which gave problems when there was an indication for pulmonary embolism. We found out that we got 3 times a false negative test result within 1 year time. And we thought, okay, this is too dangerous to implement in this way. We can't control. We don't know how many years this particular test has been in the bag of the doctor while visiting a patient. And so we said, okay, let's get rid of it. And it was out of the market afterwards. Actually, we did a research on that, and it was the pre-analytic phase, which is often the problem. Again, in this way, you need quite some blood and in a stressful situation. So there were a lot of mistakes going on in the pre-analysis. So, but now there's this new generation quantitative D-dimer tests available on these 5 devices. We checked all them, and for the first time I could say POCT device doesn't mean it is always inferior to the central lab, because in this study we showed that at least 3 of the 5 devices turned out to be better than the reference lab to do regular D-dimer testing. I have to say it is in laboratory situations. Plasma was used for those tests, so we are now busy with a validation capillary test compared to plasma. If this turns out to be again a very good, well, if the quality is good, then we're ready for introducing it. And then the GPs really want to get using it. I think 90% of our GPs, and we have about 9,000, will start using D-dimer right away. This is interesting for the insurance companies because this is used in a clinical flow already described in our guidelines. And if you, in some patients, you could use this extra test to exclude serious illness again. And that means that we wouldn't have to refer 50% of those patients. So that's a cost-effective way of point-of-care testing, for sure. Well, we got all kinds of, we call it pilot areas on hemoglobin. I would say don't do it anymore yourself. Don't do it or do it correctly with our help. I'm busy with cardiovascular risk management in a one-stop model. It's possible within 20 minutes to have your complete risk score available if you use the right tests. I have to say, creatinine is not ideal. I would like to have creatinine on other devices or maybe a cheaper ones than we have now. But in this way, we could do the trick. And then we were already talking about lactate. Like I said, we're performing a big study right now. We have already included 250 patients with possible sepsis, of whom 30 to 40% have sepsis. This, for primary care in the Netherlands, it's quite a unique study because they're all included in study at home. Am I still in time? Yeah, okay. Another project, I think it's time to get rid of the consumer testing for professionals. So it's time for professional glucose testing. We set up a pilot with those tests. And again, wow, Australia, I think you are the ones to follow in the coming years, but maybe some collaboration would help both of us. So I would like to finish that off. I think there's nothing more than this to say about official models, which are not there. I think if we invent something which works, that helps make policymakers think of how to deal with it. How do you call it? So I think we first have to set an example or many examples to get something done officially afterwards, if it comes to reimbursement or policy or regulation. So that's at least what I would like to share with you. Thank you.
Well, that was fantastic. Thank you very much. We've got time for a couple of quick questions. So has anybody got something they'd like to ask? Andrew?
Roger, you mentioned you have very clear guidelines in the Netherlands for use of tests. Some of the evidence in the literature, particularly around the economics of testing, says that you really degrade the case for cost effectiveness if GPs don't act according to the guidelines. Do you have much guideline variability or deviation, do you think, in the Netherlands, despite your promotion and so on?
Absolutely, and those guidelines are getting more complicated every day, so we need those guidelines at your electronic record, so when you type in this patient has a headache and fever, we should already have some way of flowchart helping you, because those guidelines with all those different arms and age-related groups make it a very hard time for GPs to follow them. In a broad sense, and there's research done, the adherence to guidelines is quite all right. You know, when there's a new guideline coming out, the GPs will definitely try to read them well and to adhere to it. And they should, because in official, what's the name in English? In the cases when things are going wrong, the judge will take the guideline as the basis. So you really have to feel responsible. But that doesn't mean that it's followed perfectly well in all cases. For example, with D-dimer, some doctors do a D-dimer test when there's a high suspicion of lung embolism, and you just shouldn't test anymore. You should just refer. So these are the small dangers, or at least some dangers. Your question was,
The economic effects of that.
yeah. Oh. What's your answer?
Well, I mean, there's certainly some published literature which, for Buckle's group, have said if you don't, when you get deviations from the guidelines, it becomes much less cost effective.
Yeah, probably.
This is in relation to CRP.
Yeah. Well, one reaction to that, I think the anxiety about overuse is GPs don't really like to do a lot of extra things, you know, and extra tests means extra results and extra interventions. So I think that the idea that if we introduce something, it will lead to medicalization and overuse, I don't believe in that. And we've proven after introduction of CRP, we followed those doctors for 4 years long. They didn't do any more tests at all. And I check it with my lab every year. And that's just a stable use of those tests for the right indications. Of course, a little bit more, that's possible. But I don't care if they use a CRP test for possible appendicitis or possible meningitis. But if you follow the guidelines strictly, they would say, don't use it for appendicitis because we don't know, because we don't have primary care evidence. So, yeah.
Excellent. Anything else? I know I've got a few questions that I was hoping to ask, but we are out of time. So, Roger, if you're around during the day, a few of us are going to come and see you. But that was terrific. So please thank Roger. And our next session. So the next one, financial business model for point of care testing. So we've got Ryan and Danny presenting this. Ryan is an up and coming talent in the accounting area. He's got a lot of experience with practices and his knowledge is broad, which is allowing him to provide assistance to medical practices and practitioners. Danny has a bit more experience. He's been working in the industry since 2008 and he heads up Brentnell's SA's health division. As a Sydney-sider, I don't know who Brentnell is, but I'm sure that sounds fantastic. This work was sponsored by Country Health SA. So I'm going to introduce Ali Krolig, who's the Director of Health Policy there. She'll start the presentation and then Ryan and Danny will join in. So please welcome Ali.
Hi, it's Country SA Primary Health Network. The role of primary health networks in Australia is to improve the health outcomes for patients, including access, gaining access appropriately to care, and improving the patient journey. covering rural and remote South Australia and country South Australia, the rest of country South Australia, which covers some nearly 1 million square kilometres, is actually fairly challenging. So in how we address the ability of patients to access care appropriately is really important, including how they access pathology testing and the results from that. So, you know, a person who lives in one location, they might need to drive 2.5 hours to get to a station where they can actually have their bloods taken. They've been to the doctor, they've gone to the 2 hours and then 2 hours back home again. They need to then book another GP appointment and then go to the doctor again. So it's actually quite a lot of time and effort. So with the introduction of healthcare homes, we had an ability to actually do some trialling of point of care testing in our general practices under the healthcare home trial. And Rosie Tiramaku and ICC have been instrumental in doing that for us. We've had some further funding this year, which has allowed us to expand that for a further 2 years. An important part of all of this is actually to make sure that, you know, should our funding come to an end with our ability to support point of care testing in general practice, that general practice also has an opportunity to actually understand what it might look like for them to implement a business case for it being viable, point of care testing being viable in their business model. So at the time that we instigated the point of care testing through our healthcare home, we also contracted Brentnals through Danny Haydon to do this business model, which we think is actually it's a seminal piece of work at this point in time, where there are a few ducks that are starting to line up and ready to get point of care testing out there in general practice as a real thing. Okay, thank you.
Great, thank you, Ellie. I might get Ryan to sort out the technology. It's good having these young folks around, isn't it? All right, great. Thanks, Ryan. It's really a real privilege for us to be here presenting today. It's kind of an unusual group, no offence, for us to present to. We're usually talking to practices, GPs or business owners. So it's refreshing. We also, I guess, through this project, really appreciate the vested interest and commitment that this community has to point of care testing. Through our involvement with the project, we've been captured, I think, by the importance of this work, and also, importantly, the benefit to patients, doctors, government, and the larger community. So, yeah, what is point of care testing? Thank you. Your definition, Roger, was much more expansive than ours, and I'm not going to actually go into that because I assume that you guys know this, but we're just providing that for context. As Ali has said, Brentnals Health have been contracted to investigate the prospect of point of care testing in general practices across South Australia, to look at how it can be made viable, both from a clinical and financial level, mainly looking at the financial level and the business case for that. So our project really involved the financial analysis of point of care testing, and then the development of a point of care testing analysis tool that Ryan's going to show you through, and Ryan has done the majority of work in behind the scenes to pull this together. So just to give you some context, the tests that were considered, I won't go through all the details. I'm hoping that you are all very familiar with the purpose of these tests. But the tests that we worked through with CRP, lipids, HbA1c, ACR. INR was a test that was a little bit different, because it wasn't part of the healthcare homes funded project, but something we were still interested in, but also NT Pro BMP. And in the context of rural practices, the NT Pro BMP is quite important for some of those rural practices that don't have access to the hospital facilities that are immediately available in a more metropolitan environment. So, what did the project involve? What we did was to work through time in motion studies with the point of care testing practices that were supported by the PHN. We interviewed the 6 practices across rural South Australia to gather their quantitative data and qualitative information about the process. So, in particular, looking at time, the value of time and how much that takes for the practice nurses often who were conducting the point of care testing. Also looked at the cost of consumables, the benefits to the patients and also to the practice. That data was consolidated, and then Ryan has put that into a tool, understanding all the key parameters to try and to work out the financial business modelling that sits behind point of care testing. We also had multiple progress meetings with stakeholders, which was really useful, catching up with Ali regularly and also Rosie and Gil from ICCNet. We had the privilege of some time spent with Andrew St John and Raj, and some insights into the work that they're doing as well in this area. So what we've then developed is obviously a report back to the Primary Health Network with a view for that being distributed. I believe, Ali, that's gone live on a website, the APPN website. So that is accessible. If you want more details about that, we can catch up with Ali afterwards. But I'll hand over to Ryan to go through more of the details.
All right, so as Danny mentioned before, we've developed a tool as part of this business case, and I'm just going to run you through that now. So we've researched and looked into the detail around all the costs associated with point of care testing and what costs that a practice would incur for the 6 tests that Danny mentioned before. It's the analysis the point of analysis we've taken is a break-even model, looking at a 3-year break-even, as the assumed life of the machines is about 3 years, give or take. And then we've also converted what I'm about to show you into a tool that a practice can use and put in their own costing parameters and work out if it is viable. So I will show you the tool on the next slide. And the figures in here are the figures used in our report, which you can view to see the recommended funding position that we've created from the tool. So this pointer's not working, so I'm just going to...
The pointer works.
It does it? It's not plugged in.
Yeah, but if you just press that.
Right, okay, cool. So the pointer does work. So basically, as you can see at the top here, there's a section for the cost of the nurse to go in. So basically, there's a sheet at the front that you can input all the costings into associated point of care testing, and this is the analysis sheet where you can put in the time related to each stage of conducting a point of care test for these 4 tests specifically at the moment. And then it will bring through a cost based on the nurse's hour, which is on that front sheet that you can't see at the moment, but there is a sheet with all the costings behind it that can be adjusted for practices as well. So that's looking at the cost of the time specifically taken for a nurse to complete a point of care test. And then we've also looked at the cost of consumables and made a functional sheet where the practice can put in which consumables they've used, and again from the front sheet we'll bring through a cost on a per test basis. And as you can see at the bottom here, based on the nurse's time and the cost of the consumables, you can see a total variable cost for each of the tests for completing one test. So that's the first part of the tool. The second part is looking at the fixed costs that don't occur on a per test basis. So as you can see at the top, first we're looking at quality control, and the time taken to complete a quality control test, the time the nurse takes to complete a test, and that brings through using the costing of per hourly rate for the nurses as well. And then we've also looked at the quantity of quality control per year, as you can see here, how many times quality control, external and internal, has to be completed per year, and then that brings through a cost of the nurse's time, which is quite significant just for the Affinion machine and these 4 tests alone. Then it brings through the cost of the machine. It brings through the cost of accreditation as well that we've used for the report. It also looks at training, and then again it's a nurse's time taken to complete this training based on her hourly rate, which is a cost that would be often forgotten, but that's another cost that we believe needs to be included into the total cost of point of care testing for this machine. And then looking at the external quality control subscription fees, the annual subscription fees and the costs for those you'll see on the screen now, because as I said, this is a 3-year break-even basis, so that's 3 years of the costing for each of the tests. And then also looking at a wastage percentage of around 5%, which is what we've gathered from our conversations with the various practices we've interviewed, and we believe it's a fair estimate of the amount of wastage averaged across all of the tests. So then, as you can see at the bottom, we've got the total fixed costs associated with the point of care testing over the 3-year basis for the Affinion machine and these 4 tests specifically. And then based on the volume of tests completed per month, which is data that's been provided to us by ICCNet from actual practice data, we can work out based on the total costs and the volume completed per month, the recommended funding position that a practice would then break even on all those fixed costs and all the variable costs per test at that rate of volume that we've calculated here. So that figure varies, of course, as volume increases. That figure is to go down, and it's just something we've calculated based on the data we've gathered that is in the report. However, the variation in the tool I said we created for the practices is that the practices tool, they can put in a funding figure, and they can actually work out based on the volumes and the costs they incur specifically on an individual basis whether it's maybe viable for them. So that is the tool on a general basis, and I will let Danny continue. Thank you.
Thanks, Ryan. So the table up there gives you a representation of a comparison between the pathology rebates that apply and then the proposed funding that is demonstrated through the modelling that we've worked through. Obviously, you can see the costs from a GP practice point of view is higher than what would happen in a pathology provider, and for quite a few reasons in terms of that. In particular, if you think back to Ryan's slide, the actual costs for control testing and that significantly increased the cost to the practice to provide the point of care testing service. The other thing I just also add is around the accreditation costs. The figures that we've got have been provided to us from ACPAL as one of the accreditation bodies for general practice. So we went back through to them and looked at their process and asked them to provide us some indicative costs of what they thought that cost would be for general practices if they were conducting the accreditation process. So this is not the same as a NATA process. This is actually the accreditation that is run through general practice under the general practice accreditation standards. So some of the qualitative factors are things that we needed to consider in the report. Is, as I mentioned before, the cost in general practices is higher. Most of general practices are using either a registered nurse or an enrolled nurse to do this work, and those costs would be are significant. the costs are also, I guess, higher than what you would see for the pathology providers because of, as I said, the reasons before. They've got so much higher volume and the ability to spread those base costs across that higher volume. So in terms of practices, the economies of scale, we also considered the issue of larger practices versus smaller practices. Even in rural areas, we see some large practices with 15 to 20 GPs compared to the solo practices that are trying to operate. What's the impact of that? How does it impact on them because of that base cost that would be incurred, the non-variable costs that Ryan mentioned? And we do view that there will be some economies of scale generated as volume increases, and practices over time are likely to increase their volume of testing. And I think Roger previously alluded to that in his presentation, that volumes are certainly increasing. The next part that we looked at was about efficient access to care. And Ali spoke about the challenges of the tyranny of distance for some of the patients in rural areas and access to care. Even if you're living in a town or even in a metropolitan area, that inconvenience of having to go home, then to go to a pathology collection centre, and then potentially having to go back to the GP to get that result is certainly simplified by point of care testing. There's a huge patient benefit for patients who, one is to reduce their time, to be able to receive that feedback at the point when they have the test done, making that feedback on their results more meaningful. And the other issue is about the point of care testing being less invasive than the testing done in the collection centre. And for patients who are having frequent testing, that is certainly an advantage. In terms of the public health benefit, obviously you're aware of the benefit of CRP, and I think if we can see CRP being utilised more within general practices across Australia, we can hopefully see the reduction of unnecessary antibiotic prescriptions. And finally then, in terms of efficiencies within the practice, we see that there will be efficiencies over time for practices as they get more used to delivering point of care testing, and obviously make the cost effectiveness for the practices much more economic for them. So the big question coming out of our report is, how does this get funded? And in general practice, predominantly over the last nearly 40 odd years since Medicare has come into play, medical practices have become, I guess, wedded to MBS items in terms of delivering funding. And so the first area that we looked at was a full MBS model. So what if government was to actually provide a rebate that I guess matched the cost of delivering that service based on this model? Now, in that scenario, it requires, I guess, a break-even volume of tests to remain viable. So if you're a practice and you're receiving a rebate from the government, you would still need to, over that 3-year period, achieve a certain volume to break even. Now that might be easier for larger practices, it might be more challenging for smaller practices. The financial risk of that model to the practices, if they don't break even, they would not, it would not be as financially viable. But if they were to, they could potentially, I guess, achieve a financial gain if they were able to get to their volumes over that break-even mark. Roger talked a bit about general practitioners not necessarily being looking to I guess, to over-service in this situation, and I think I would concur with that. But the modelling of using a fully MBS model does raise that opportunity for practices to provide more services to generate greater margins. The margins are so thin that I'm not sure that a practice is going to be out there to try and game out of this. But the reason we talk about that is we wanted to talk then on the second model, which is a part MBS model and a part practice incentive payment model. So GP practices have received block funding through the Commonwealth for specific tasks that they do to help, I guess, support their infrastructure and the services that they provide. It's not based on activity, it's not fee for service, it's practice incentive model for achieving certain outcomes. And our position in this paper is that we think a model that blends both an MBS for the variable costs for the tests and then has some practice incentive funds to fund the non-variable costs would be a better outcome. It means the non-variable costs of equipment, accreditation, quality control testing would be covered by the practice incentive payment, and that would remove the benefit for larger practices over smaller practices. It'd be more cost neutral and not volume dependent. And so in this table you see there in the part MBS PIP model, we've stripped out the non-variable costs to leave just the variable costs there that would be recommended for a part MBS and a PIP type of model. Obviously the costs have gone down to some degree, and for some of the tests, especially the PMB, that's a significant cost reduction. You can see here on this chart just shows you the different models. A fully funded model, because you're looking for that break-even situation. Until you get to that point, the practice is in a negative position. Once they get to that break-even point, they're in a positive position from that funding model. Whereas if you consider the part MBS PIP model, that's going to be cost neutral all the way through, regardless of volume. There is a third model that we considered as a service incentive payment or a bundled care approach. The Healthcare Homes Project is a trial that is looking at bundled models of care and bundled payment for practices, and we're still looking at how that is going to evolve in the future. I guess the concept is that as part of a patient's bundle of care for their chronic disease, that the costs of their point of care testing would be included into that bundle. I guess one of the limits to that model is, apart from the fact that we don't have line of sight of the implementation of that model and how effective it's going to be, one of the limitations is that it is really there for patients with chronic conditions, and there are some tests, the CRP being an example, where it's not limited to being used for patients who have chronic conditions. So to sum up, I'd also reflect, Roger mentioned the quadruple aim before, that we certainly see that point of care testing in general practices has a real opportunity to deliver improved patient experience, improved population health outcomes, also improved cost efficiency and sustainability, while the rate, the rebates that we've talked about, the funding per test seems higher when you factor in the whole picture of point of care testing and what it can achieve. We believe that that's going to be a much more sustainable model. A lot more research and development is probably needed to go in behind it than what we could do in our project, but certainly there's some good indications there. And finally, improved health provider experience. The frustrations for providers with our system at the moment and the fractured nature of it, the inability to just deliver the care and provide that information directly back to patients is palpable. Point of care testing offers for our practitioners a real opportunity to get those tests done and have a meaningful conversations with patients right there at the point of care, and for the patient to go home with clarity about their care plan. So thank you very much for the opportunity to talk to you today. I'm hoping that we've got time for a question or two. Thank you.
And in fact, I hope you don't mind, I'm going to jump in with a question of my own
Sure.
first. So you've come out with some costing based on looking most at the full service model. You mentioned that it can be dependent on test volumes and practice sizes. What size practice did you use to get those numbers, or can you give us an approximation?
Yeah, the practices varied in size. So, and it's interesting, size didn't necessarily actually add up to usage either. So within the practices at this stage, because GPs aren't familiar always with using point of care testing, it really takes the doctors, the practitioners and the staff who are captured by it and see the real value of that. So I think that'd be fair to say that we haven't had, we've had solo practices versus practices with up to 14 doctors, and the volume actually didn't correlate directly with the number of practitioners.
Yeah, the other comment is for BNP, we're using it in a different environment. Traditionally, we use BNP to exclude heart failure in the ED, but here we're using BNP to manage heart failure patients. So it's going to take a bit of education, so we anticipate that now the program's been extended, the usage of BNP will increase, and so that cost per test will certainly drop off. But it's an education process of how it fits into a GP practice. We've had one webinar that Phil gave to us for GPs, and we'll be doing a lot more of that and helping them integrate the tests into clinical practice, because we believe the best integrated in clinical practice going in.
Yeah. The most difficult part of the analysis is the volume. It's the most uncertain area, and so we've I guess been able to use some of the data that we've got through from ICCnet across broader practices, but that has been the most challenging part.
Yeah, thank you.
Thanks.
And sorry, any other questions?
Just got a question about the PIP model. How, if a practice is receiving that it's NPACC, how would it be followed up? They're doing their quality testing, that the patients are actually getting access to that point of care testing, and then giving an incentive to do it if the practice is getting it.
Yeah. Yes, the Commonwealth is good at compliance in terms of putting in measures, and I would expect that Commonwealth will have line of sight over what tests are being claimed through the MBS system, and whether it's being utilised or not. The accreditation process will then look at the standards and review the processes that the practice have in place and ensure that there's some compliance in that regard as well.
Excellent. Well, we are at an end of this session.
Thank you.
So please join me in thanking these guys for their contribution. Thanks very much.
Yeah, cheers. Thanks.
Thank you. Alrighty, our next session. So it's entitled Impact of Introducing Point of Care Testing, Flu Testing. It's going to be presented by Robert Booy, who's the Head of Clinical Research at NCIRS. And his research extends from understanding the genetic basis of susceptibility to and severity of infectious diseases. No, it doesn't. I'm lying.
You don't need the detail.
Oh, okay. I just wanted to touch on, most specifically, flu. So, yeah, please join me in welcoming him to the podium. Yeah.
That's all right.
Good afternoon.
Okay. There, isn't it?
Thank you. That's great. To continue the theme of Dutch presenters, I'm Australian, but my name is Dutch, and my parents came to Australia a fair while ago with all my older brothers and sisters, so I can speak Dutch. So I could read those slides.
I want to change the theme just a little bit around point of care testing, and I want to challenge you to tell me about how to do things better in South Australia, because you had a big issue this last winter with influenza, and particularly with outbreaks, hospitalisations and deaths in aged care facilities. Now, you may think it's strange that a paediatrician is talking about this, but I've been involved with flu in the elderly for 15 years, and previous research using point of care, which was antigen-based and much less reliable. So, as the slide there says, that residents in aged care facilities are often in their 80s and 90s, and they're at much higher risk of developing complications from influenza, and earlier detection could make a real difference. Now, the model that we've been going through in the last year or so in Western Sydney has been to work really closely with our public health unit. And this is where I'd like to compare and contrast with what you do. We have a director of public health and nursing staff who specifically are told by nursing homes when they've got an influenza outbreak, which is defined by within 3 days, 3 symptomatic people with flu-like symptoms. And then the key point of care test that we do is that we're looking after 65 nursing homes, so to speak. We work hand in hand with them and with the GPs who care for them. So then we will speak on the phone, and when there's a likely outbreak, even 2 coming up to 3 cases, we'll go out within hours and take the point of care machine. And it doesn't really matter which machine it is, because they're all producing results now within 30 minutes. And we were using one last year that was taking an hour, but that was still fantastic compared with the 3 days it often took to diagnose outbreaks through the old route. So I want to come back to that concept and about how you manage that here in South Australia, because I wonder whether we could potentially work together to diagnose, identify the outbreaks much more quickly, and then act. That's the key point. There's no point in having information unless you act on it. So if you can act, prescribe and fill the prescription and have the patient treated, then within a day you can make, I believe, a real difference to the size of outbreaks and the lengths of outbreaks and the outcomes. So I come from a background in immunisation, so I'll spend just a minute on this, but I think the epidemiology and the vaccinology of flu is highly integral to this whole point of understanding how to diagnose when you're not always able to prevent. Now, as a paediatrician, we've been achieving 95% with GPs especially, and the nurses who work with them, 95% uptake for routine vaccination in childhood. But for classic routine vaccines in the elderly, we're lucky to get 70%, sometimes only 50% uptake for things like flu and pneumococcus shingles. Now, we also have much less effectiveness in the elderly. We've got high burdens of disease, both mortality and morbidity, effects on quality of life and economic impacts as well. You know all that. And the immunosenescence, our immune systems get worse and worse as we get older, so we're less able to respond both to infection and to immunisation. So just a few facts about what's happened in the last 3 years, and I hope I might inform you about South Australia and Australia more generally in regard to flu. Now, 2017 was really the key big year. You know, if you've been following the media this year, they'll keep telling you it was worse this year than ever, but actually it won't, and I'll explain why in a couple of slides. 2017, 250,000 notifications, and together with that, proof of severity, because perhaps 1,000 deaths, mostly in nursing homes. So a really big year in 2017. It also affected children under 15, and hospitalisations in children were especially more common under 2 years of age, but 90% of the deaths were over 65, mostly over 75. So that's 2017, and it had an immediate big impact on herd immunity, which is built up by immunisation, but also by natural wild infection. So the best explanation for why you had such a quiet year in 2018 is probably that there was much improved community immunity or herd immunity, less transmission, and so we got much less disease during the winter of 2018. There was a nadir. Just as an interesting point of fact, a century ago when we had flu outbreaks, we didn't have a winter pattern at that time. So that's interesting to reflect. Flu's been very much a problem of conurbation, of people coming together in larger numbers. And then 2019, we all know, was very strange. And it involved flu kicking off already at the end of 2018. And across Australia, during the autumn, people were reporting 3 times higher rates of flu as per normal for that time of year. So it wasn't huge, it was just 3 times a low level. And in South Australia, it was 5 to 7 times higher. You really had a big takeoff in 2018. And my simple explanation is that we got, first of all, an H1N1 outbreak early in the year up in Darwin, and that spread down to South Australia and was measured here in South Australia within a couple of months. And as well, we later got H3N2 causing surges, and we had this background of reduced community immunity from not having had much disease in 2018. Immunity to flu can last between a few months and decades, if not scores of years. People who were alive in 1918 were protected 80 years later against the 2019 pandemic from the memory that they had. So it's curious, flu immunity can be just a few months, and vaccination may only last a few months, and I'll come back to that in a moment. Or if you have a wild infection at a young age, and that impressionable time when you first see flu, you may get prolonged immunity for a very long time. So I hope I've kind of explained the last 3 years in a snapshot, which is useful to you. So vaccination, because of immunosenescence, because our immune system doesn't work so well, is helpful to the elderly, and if I want to leave you with a figure, perhaps 40 to 50% protective. That's not perfect, but it's better than anything else. However, we need more. And I'll let you read that and just go to the last paragraph. Herd immunity, which I've been touching on, and which comes from both vaccination and as much from wild infection. When there is a big year like 2017, it really can work together with vaccination to provide protection. But then only a year later we lose it. So it's a very tenuous concept and hard to achieve unless we get very high vaccination uptake. Now this is summarising the epidemiology of hospital admissions for flu over a prolonged period in Australia, and obviously under 6 months before you can be vaccinated, and when your immune system is naive, you're at more risk of hospitalisation, not really death, but then over 65 is when death occurs. We now have routine immunisation for children under 5, 6 months to 5 years old, and it's not just for at-risk people, and that you know well, and I won't labour. But this is where I'm going to give the explanation, which I think why we're having the media telling us we've got more flu than we really have. And so if you look at 2017, by confirmed cases, notifications, you can see it was a stonker. It really was much higher than the 5-year average, and curiously, much higher than 2009. Now, is that real, or is that a perception? And where would that come from? So I'm going to put to you, why was 2017 so terrible? And is there a double truth? And I hope you're guessing at the 2 truths that explain 2017 already. If we look at just presentations to GPs, the people who came in with a bad cold or a flu, not tests in 2009, just presentations, then there was many more cases presenting in 2009, the pandemic, than 2017. Whereas the previous slide, it was the other way around. So there's a simple thing that's happened. We have in the last 10 years massively increased the amount of testing we're doing in primary care especially. And so now that 2017 looks, in terms of ILI presentations, influenza-like illnesses, it looks less than 2009, but it's actually, when you look at notifications, it's much more. And it's a real testing phenomenon. So isn't that fascinating? And if we look at notifications, there you go, 2017, when you actually tested, the 2017 is again the much more common one. And so it's because of testing and because it was a bad disease as well. It's a double truth. The epidemiology was bad. And this year, by testing, it looked even worse, but it wasn't. We had probably half as many deaths in nursing homes, for example. So every year it's changing. You can't compare this year with last and be certain of comparing apples with apples. So here again, I've shown the confirmed flu notifications and especially the prominence in the elderly. But look what happened. Almost a half of aged care facilities 2 years ago in New South Wales, nearly 600 of just over 1,000, 300 deaths proven, 72% flu A. So that was really bad. And then you had that somewhat worse yourselves this year in South Australia. So that's a Dutch word for you. Wow. So I hate slides like this, but I'm going to walk you through it and I'm going to make it really easy. If we look at flu vaccine in 2017, when there was a problem, it wasn't well matched to the vaccine we were given. You can look at all ages and you can say, well, about 1/3, top right, about 1/3 protective. Not great, bordering on good, but not terrible. But that's all ages. If we then look at the most prominent flu AH3, which came along first 50 years ago in Hong Kong, then we see a problem because that's the one that kills old people, AH3. And there we've got next to no protection. The confidence limits include 0, so there might be 10 to 15% protection in people who are adults, but it doesn't seem like it's working at all in people over 65. So there's a simple message there. We needed a better vaccine, and we did get a better vaccine the following year for 2 reasons. We got a better match, and we introduced enhanced vaccines as well. And these were the enhanced vaccines, Fluzone and adjuvanted vaccine. Both of them have been tested in large populations and provide probably 25% better protection. So if you've got 40% protection from standard quadrivalent vaccine, this enhanced vaccine, one or the other, will give you 25% or 40% more, which is an easy sum, 10%. So it's not a massive improvement. It's a meaningful improvement from 40 to 50, but it's not massive. Okay, so this is why we need more than just vaccination. Vaccination is simplistic and it's not good enough yet and it needs to be refined and improved. So we've been doing management of flu outbreaks in Western Sydney now for over a year, and it's done with 1.5 nurses and a PhD student and supervision from the public health unit and my involvement as well. And it's basically down to good preparation and good cooperation with the powers that be in nursing homes and with GPs. And so there's planning and there's standing orders for Tamiflu, oseltamivir, so that if people want to prescribe it, it's available there and then, or can be obtained within hours. So this year, as opposed to nearly 600 flu outbreaks in New South Wales, we've had about 300. And the year before, we had only 44. So I want to tell you a little bit about what's happened in the first 9 months of surveillance, which began in August last year. First of all, because it was a non-flu period when we started, about half the outbreaks were not flu, and they themselves were causing some hospitalisation and death, which is an important observation. We also saw that some of the outbreaks lasted for some weeks, suggestive of multiple introductions by staff and relatives and ongoing transmission within the units. This is one of the machines that we've been using. It's a gene expert. We can do 2 at a time, but, although had we had one of the other newer machines, you can do 4 at a time. For us, we started over a year ago, it was taking an hour. It's now down to half an hour. So that's a big improvement. And it's really been revolutionary to have this, to be able to take it on the back seat of a car to a nursing home. Then we can, with a small team, look after 60 nursing homes in close cooperation with those GPs and with staff in the nursing homes. So we think this is more cost efficient than trying to have it in every GP practice. Which is not to say we don't want to work very closely with the GPs. And we're empowering them to commence prompt and appropriate antiviral treatment and prophylaxis for those who are contacts in the nursing home. So when we educate the nursing homes, we've actually been out to nearly 50 of them to have a session for an hour or two to talk over how to better manage flu outbreaks. The identification of nearly 3 cases within 3 days, and the number of symptoms can sometimes vary, and then the confirmation, and followed by the rapid response. So the methods are as set out here. We're working very closely, actually within the confines of the Western Sydney Local Health District, so it's very practical. It's not sort of a bolt-on project. The nurses who work on the project are integral to the public health unit. I want to give you the results of the first pilot, where we looked at about 75 tests in about 16 nursing homes using the Gene Expert Express. It's a reverse transcriptase PCR assay, and we've been looking for influenza A and B as well as RSV, and trying to get there within a short period of time. I'm just summarising the identification there of flu symptoms which would suggest doing a test. According to the national guidelines, you need to have 2 positive point-of-care tests, but it's proved to be so reliable, I'm going to say that we're thinking that 1 positive is probably good enough, because it's the same machine that we use in the nursing home as is being used back in the lab, or a similar machine. And then it comes to management, and there's all the subtleties of doing a good job of infection control, isolation, monitoring, reassessing, quarantine, shutting to new admissions, all those sort of practical things that I'll show you again in a moment. So if we have 2 specimens tested, we're able, as part of the infection control team from the public health unit, to declare an outbreak, and that's done immediately, and the GP is contacted and the information is shared. If necessary, we work with the New South Wales state antiviral reserve and provide that, but if the GP's already got things under control, then he or she goes ahead. So obviously there's no need to wait 2 days for a pathology test. And the facility does these things that I've just already alluded to. Very good infection control, controlling movement, getting data collection going right from the beginning. If staff are unwell, sending them home, preventing new admissions and stopping visitors from moving around too much. So this summarises the approach. And if you go to the bottom box, the swab is still delivered to the lab for confirmatory testing, and that's important because we were doing a pilot, and we actually do a full respiratory screen with 10 or 11 viruses checked for, so a slightly different PCR, multiplex, and that has its own complexity, which I do want to go into very briefly. So about 75 samples, 16 nursing homes. What we found were 20 positive results and 53 negative. Now, of those 20, 3 were what we would say epidemiologically linked to another case that was proven flu and had symptoms, but was a low positive on our test, on our point of care test. And then when they took it to the lab, it came out negative. Now you then have to ask, did we have a false positive, or was the lab a false negative? Well, the lab themselves have said that our results are true positives, not false positives, and they have a false negative. What happened? Well, the threshold for detection was just over 30, and the lab used a dilution step, a time step, and in looking for 11 viruses, it became less sensitive than it was in looking for 2 or 3 viruses. And that's the lab people talking, not me. So to summarise it there, the lab staff noted on the second line that the routine dilution with universal transport media can lead to false negatives following a positive point of care with Gene Expert. The 3 cases that were symptomatic were actually linked to a proven flu case, so there was an epidemiological link, and the rest I've said already. So it seems to us that this pilot, and it is just a pilot, has shown the test to be highly reliable, and it may lead to a change in the national guidelines, given that these point-of-care tests are now almost routinely having sensitivities and specificities of over 95% for both, for at least 4 nationally available products. So deductions, conclusions. The study found that the point-of-care test to be reliable and practical, and changed practice and sped up practice. We had timely use of antiviral treatment and not of antibiotics. And we showed both specificity and sensitivity, and importantly, it was easy to use, and it was being used by nurses or in fact the PhD student who did not have a background in health and was able to use it very ably. So there's the PhD student in the middle, and he's very proud of himself for working out how to use the machine so quickly and effectively, and the clever nurses are on either side of him telling him what to do. Some of the concerns amongst staff is that not all staff could operate the point of care testing. Well, we're running it with the public health unit, so that takes that problem away. One of the concerns we have is that very often in outbreaks, the first member to become unwell is a lab. To become unwell is a staff member. And especially staff without clinical backgrounds, they might be involved in activities, were more likely to spread the infection because they were more likely to come to work when ill and have somewhat unrestricted movement. So that's practical concern. There are other infection control concerns, cough etiquette, use of personal protective equipment, etc. I won't bore you with all those details. You can read them more quickly than I can say them. Exclusion of staff I've mentioned already. Isolating the area. Sometimes it's just a wing that we can take care of, and visitor restriction. You know, relatives get upset, so we work out ways to communicate nicely with them so that they only visit their relative and don't go anywhere else and spread infection. So I have to say all these things because it's not vaccination, it's not point of care testing. It's a holistic, thoughtful approach, bringing together all of the stakeholders in a way that can make, we believe, a real difference. And they agree with me. Thank you very much.
All right, fantastic stuff. Do we have any questions? Yes.
You've clearly demonstrated there's a need in the aged care facility. Have you thought about the emergency centre as a
Yeah, there's quite a few people thinking about that, and they've done some work in Melbourne in those regards, and in some other, I think up in the Hunter in north of Sydney. So there's a few people working in this area. I'm not across all their work, but clearly A&E would be a great place. Back in 10 years ago, we were trying to push for that in our own A&E at the Children's Hospital with simple antigen testing. And we got into opposition from some of the hospital staff with having it in the A&E instead of just in the lab. So you've just got to work out the cooperative approach to making it happen, but I agree that's a high density area again where you can get a lot of turnover and likely reliable results.
And anyone else? Sorry, just continue on from that point. So looking at the PCR testing as opposed to the standard sort of rapid test, which may have more of them out there and a higher throughput, do you see a much greater value in being able to do PCR and typing?
Well, for flu, we've got an antiviral treatment that is only going to work at a efficient and effective level if you get it in quickly enough. RSV, we don't really have affordable, effective treatments yet, but for flu, we don't need to know whether it's flu A or flu B or flu H1 or H3 because the antiviral is fairly consistently effective across all. So, there are implications. When you do a test, we always want to know what's the implication of this test for the patient and for the family. So, this approach that we've got seems to be more affordable, having one machine that we take to the patient. And if anyone has got any ideas, not now because we're out of time, but in the lunch hour, I'd love to hear from you about how to make something like this work in Adelaide. There ends the ad.
Thanks very much, Professor Booy. Before you leave, thank you, gift from all of us, and please join me in thanking Professor Booy for his talk. I feel a bit superfluous introducing our next gentleman. Wilton Braund, everybody knows quite well, I'm pretty sure. He's done a lot of work. Wilton's an endocrinologist, done a lot of work with HbA1c testing. He's also got a lot of history with technology being used in the medical setting, and he's been heavily involved with the MSACC application for HbA1c testing, and he's here to tell us how fantastically it's going. So please welcome Professor Braund.
Professor Booy is a paediatric physician who works with the elderly, and I combine both his areas of interest. I'm an elderly physician and also a computer tragic. This is the one that works, isn't it? The pointer? And that's how it's done. Fantastic. Statement of bias and interests. I've given paid lectures on behalf of pharmaceutical companies whose products I'll mention. I don't have any relevant shares or patents, and I do have a financial interest in software that manages point-of-care testing devices, so every time I mention the word point-of-care, you know I'm doing an advertisement for my product. I was invited to present a clinician's viewpoint to the MSACC by a previous iteration of that HTA-IVD submission. I wasn't invited to take part in the second submission. That may tell you a bit about me. I did react assertively when they said that they shouldn't let nurse practitioners perform point-of-care testing, which is bizarre to me because I visit Mildura. There's a nurse provides a continuous diabetes service in Mildura. I go up there every 3 months and give it the gold stamp, but without her the service wouldn't exist. And she's done a master's in diabetes nursing. She's entitled to order tests from laboratories. She's entitled to prescribe drugs in diabetes, but apparently the MSACC thinks she shouldn't be allowed to do a point-of-care test. So maybe that's why I wasn't invited for the second iteration. Did I say irritation? Okay, so this is the document we're talking about. HT Analyst submitted it on behalf of IVD Australia. I won't go into any internal politics there. New and emerging medical services, that's their job. MSACC advises the Minister on the strength of evidence relating to the safety, effectiveness and cost effectiveness of new and emerging medical services and technologies. Why, after 30 years, is hemoglobin A1c at point of care now an emerging and new technology? There's something been going on in the background. I won't go into that. I lose friends when I do. So I've said there are many answers, all of them complex. Is there hope? Well, MSACC indicates it was supportive, so no worries. But before making a final recommendation, to to ensure testing practice cost neutrality. Cost neutrality is so important to these people, not improved patient care, cost neutrality. The appropriate quality assurance standards and accreditation of practices needs to be determined along with costs. Noted to be desirable single set of standards, NPACC, currently undertaking review. So here we have all this, appropriate single set of standards. Now, the NPACC, I think, is giving the next lecture, and I'm hoping the lady giving it will be disappointing to me, because I'm predicting they're going to be causing delays, but I'm hoping she'll disappoint me and say, no, we're doing it right now and there'll be no delay. I'm not sure who's doing it. I think she's laughing at me right now. And the other thing is this word appropriate. Now, the point of care tool is for anaesthetists, GPs, emergency specialists, physicians and nurse practitioners. And how many of them have been represented in this NPACC deliberation? And therefore, will the results of the deliberation be relevant to the physical and personal environment that they work in and to their cost structure? Again, I hope to be disappointed. Coning assumptions. I suspect most people here are familiar with coning, but some may not be, so I'll just explain it. If I, as a physician, order 5 tests, Medicare will reimburse the laboratory for all 5. But if you change my qualification to GP, Medicare will reimburse the laboratory for 3 tests, and the laboratory has to do the other 2 tests for free. Now, Medicare may not want to kill the goose that lays a free egg. And they've been doing that a long time. I won't explain their reasons, and I won't discuss whether that's sustainable for much longer. Now, a full suite of type 2 diabetes tests, because type 2 is the big one here, it will include electrolytes, creatinine, urea, liver function, hemoglobin A1C, cholesterol, triglycerides and HDL, urine albumin, creatinine, and there are more tests if there are comorbidities. So if the patient is on an anticoagulant, you may want to be checking their hemoglobin from time to time. If they're on thyroxine, you may want to be checking their thyroid function test from time to time. Equally, if the patient comes in with a problem with their comorbidity, you may say, oh, I'll quickly throw in some of your diabetes tests that we're going to do next month. I'll throw them in now. And so it'll go along as a big panel to the laboratory. And the laboratory loses money, and therefore it's very exciting to Medicare to maintain cost neutrality and not disturb that equilibrium they've got. Hemoglobin A1C can be repeated anywhere up to 6 times in a pregnancy. The MBS will only reimburse 4 in any calendar year. Once you've got a patient very stable and they've got type 2 diabetes, it's arguable whether you need to do it any more than once per year. Urine albumin, creatinine, you again may need to do several to start with and then find that you only need to do it once per year. Accreditation and quality assurance costs were discussed and were presented by the sponsor. And the question is, are these real-world costs? And we've just heard a group start discussing real-world costs, and they plan to go out and work with the Rural Primary Healthcare Network. And I think it'll be very interesting to hear real-world costs. And indeed, I was hoping I could be declared an honorary member of that network and you'd come to my place and look at my costs. What is the business model for an individual GP or specialist practice? Well, we might be prepared to accept a loss on an inadequate Medicare reimbursement if there were big savings on the cost of chasing results from conventional laboratories. Now, I work in a group of 8 endocrinologists, and endocrinologists love doing tests, and some of the tests we do have to go interstate. So we spend a lot of time chasing tests. Our practice, chasing tests, when I've done the time and motion study, costs us $2,000 per week. I'll just let that sink in. We might be prepared to accept a bit of a loss on our point of care testing. If point of care testing supports visible excellence in the practice, the patients say, these guys are great, they do the tests right on the spot. This is a good practice. So it's good marketing. If appointment slots are freed for a more profitable use. Now, we've got one appointment up here in which we're going to meet the patient, make an assessment, order the tests. Then they're going off to have an appointment with the lab, and then they're going to come back for another appointment down here. Now, many GPs charge a gap fee for that first appointment. And if you move the testing up into there and then start changing the appointment, it becomes more complex. You are, as a GP, not as a physician, but as a GP, you're allowed to increase from a level A to a level B or a level B to a level C. The appointment becomes more complex, and therefore you can charge more. However, many GPs are embarrassed about charging a gap fee for the follow-up review of blood tests, and they'll often charge that at Medicare fee only or bulk bill for it. If you can move the tests up in there and make that more profitable and free up this slot for a new other patient to come in and to be charged a gap fee, then you have made this more profitable. The other thing is, if that other patient can come in and they say, sure, we've got an empty appointment for you, that again gives the appearance of excellence in that practice. It's more responsive to their needs. The other question is it less frustrating for the doctor? I've done a little study on my patients, and 40% don't have their tests done before their appointment. Now, some of them, it's my fault. I just forgot to write the test request. A lot of them, they got the test request from me. I can look at my computer, it's there, and they just haven't been. And let me point out that every patient who comes to my rooms gets an SMS reminder 6 days before that they should get their blood test done. And still only 60% go to the laboratory. And it's understandable, because going to the laboratory is the biggest cost of time for diabetes patients. If you look at diabetes patients who take time off work for illness, it's exactly the same as the time taken off by non-diabetic patients. But if you look at the time diabetes patients take off to visit doctors and laboratories, it's about 4 times higher than non-diabetic patients. So they can't be bothered. And I get grumpy, etc., and I don't see it through their eyes, I see it through my eyes. We could wipe this out. The other thing I find ironic is that MSACC wants it to be cost neutral compared with a system that doesn't work. That we talk about, is this as accurate as a laboratory test? It's a darn sight more accurate than the 40% of tests that weren't bloody done and there was no answer. So I think this is irrational, the present approach being taken. Anybody who disagrees with me is irrational. So I think we should be doing lipids. They reduce macrovascular disease. Macrovascular is large arteries, things like coronary arteries, leg arteries, arteries to the kidney, stroke, brain, heart attack. Microvascular is retinal disease, nephropathy, neuropathy. So we've got this false dichotomy, but it reduces macrovascular disease to treat lipids. And I think we could do that at point of care reasonably well, and again, much better than the 40% who never get it done. Treatment is easy. You start them on a statin and you tell them to eat more vegetables, and that's about it. I know Phil makes it look more difficult than that, but you know. But the other thing that's really easy is you can tell who is adhering. I'm not really interested in targets. Phil has to do that because his patients already have established disease and life-threatening coronary disease. But I personally think that for primary treatment, probably just sticking them on the drug and closing your eyes is probably great work and cheaper than what we do now. But many people still recommend you treat to target, so they then do extra tests during the course of the year. But the drugs are so good that you can tell just by doing a test whether they're adhering to the drug. And as soon as the cholesterol rockets up, you say to them, well, you didn't take your tablets. Oh, no, I went on holiday. And they didn't take their tablets. And so this is a very good tool for assessing adherence. There really aren't many other drugs where you can assess adherence this well. Probably the only other one would be warfarin. And frequency of testing depends on your assessment of the patient, you know, whether they are good at adhering. And you might say, well, this person's a dickhead and they don't adhere, but more likely it's that this person is a 50-year-old woman with 3 teenage sons who keep on growing out of their Nikes, and to save money, she's actually economising on her prescriptions. And that actually comes to another question, which is where would be the smartest place to be doing lipids? And this is a heresy, and please don't talk to the AMA and say that I said this, but should testing be done at the site of purchase of statins? Would it be more powerful for a pharmacist to say, look, you left a 6-week gap between prescriptions and you notice how high your cholesterol's gone in that time? Would that be more powerful than me banging on in my surgery? And so I'll just raise that heretical moment there. Serial measurements of blood pressure and urine albumin creatinine have revolutionised type 1 diabetes, and we can see they're now going to revolutionise type 2. Until we did this, 30% of type 1 patients who'd reached the 20-year mark of their disease were already on dialysis or transplant. Not on the brink of it, but already on it by the 20-year mark of their disease. Within 15 years of us realising that measuring blood pressure, managing it tightly, measuring urine albumin creatinine, managing it tightly, within 15 years it was down to 7%, and it's down to less than 5% of people at the 20-year mark. Some of those are angry young men will never be able to help, but there we are. And is it good for macrovascular disease prediction and prevention? And the answers have come in for type 1 diabetes, and they're yes. Here we are, 1984. We're getting on a bit now in time since then. Morgensen published a study he'd been running since 1976. He first published it in 1976, and it was a very impressive study, but people dismissed it because there were only 16 patients in it. But by 1984, he was able to publish in the New England Journal with a group of 232 in whom he had not intervened, and he showed that microalbuminuria predicted renal failure and cardiovascular death. And then a decade later was able to show that 3 interventions work: tight management of glycemia, tight management of hypertension, and the use of ACE inhibitors or A2 receptor blockers will postpone or prevent renal failure and stops progression of microalbuminuria. So what's progression? Oh, we'll come to that in a minute. I just want to say these studies have now been done in type 2, and the first was the ACCORD study, and one arm was looking at the effect of very tight glucose management. We're talking about a target hemoglobin A1C of 6.5%. And lo and behold, when you set a target for A1C, you kill people. There were increased deaths in that group, and they had to stop the tight management arm prematurely. Microvascular disease was reduced, but no improvement in macrovascular disease. It's possible that these studies don't run long enough, but the UK prospective study did run for 20 years, 10 years medium, and there was only a tiny improvement in macrovascular disease that didn't reach statistical significance. The advanced study also had a tight glucose management arm. Fortunately, everybody survived. And it was cross-randomised, so there was also a tight blood pressure randomisation as well as the tight glucose randomisation. And the tight glycemia management reduced albuminuria progression only and did not affect macrovascular disease, and it increased weight gain and frequent hypos. And the reason I put circles around those is not to be alarmist, but it shows that doctors for ages were banging on to their patients about diabetes. We had a whole bunch of people called diabetologists who did nothing but bang on about blood sugars. And it's far better to back off a bit on that, not kill them, not make them fat, not give them hypos, and put some of your time into managing the lipids and the blood pressure and the microalbuminuria. And of course, I'm about to tell you, I think we should be doing that at point of care. If we do that, we will save many more lives than continually pressing the hemoglobin A1C pedal. Now, the tight blood pressure management arm reduced macrovascular events and reduced albuminuria progression, but this was a surrogate endpoint only. Was it of clinical meaning? So they ran the study ADVANCE-ON with 8,000 of the original 11,000 patients in ADVANCE-ON, and they followed them up to see whether the progression would produce end-stage renal failure and cardiovascular death. Albuminuria is measured as an albumin-creatinine ratio, mainly because if you do the 24-hour urine albumin down here, patients are so inaccurate at 24-hour urine collection that you introduce so many more problems than you fix. Just don't do it. It's just not worth it. The reason for the creatinine in the denominator is you've got an untimed sample, and you can just correct for any concentration effects by showing that the creatinine was as concentrated as the albumin. So I've got patients who show enormous ranges of variability of the albumin, but the albumin-creatinine ratio is steady as anything. And the cut-off points are different in men and women because men have more muscle bulk, therefore produce more creatinine, and therefore the denominator is higher in that ratio. And the accord-on results were adjusted. Some people would say manipulated. I think either word you use, I can say I've looked at it and I thought it was pretty fair, and I hope you'll take my word that it was. So here it is. I'd like you to look at the bottom half after adjusting for regression to the mean. Over here, it is very clear that rising microalbumin or progression from microalbumin to macroalbuminuria predicts end-stage renal disease. This included also doubling of creatinine as well as dialysis or transplant. It's probable that declining microalbumin reduces kidney disease. We'd need bigger numbers and longer time. But most interesting to me here is that the first time we're seeing that you've got a signal you can use for macrovascular disease in your prevention package, decrease of this adjusted microalbuminuria is associated with reduced microvascular disease and overall death, and steadily increasing albumin creatinine is associated with an increase in macrovascular disease and an increase in death. So, I believe there should be a reimbursement for point-of-care testing for albumin-creatinine ratio. One of the first efficiencies there is the patient brings you the urine and you say to them, when did you do that urine? They say, just now. And you said, that's in the bin and you haven't done the test. It's a great efficiency. You only want one that was measured on urine that formed in their bladder when they were horizontal. Because as soon as you start walking around, you get fluctuating levels of albumin in the urine. And so if you want to be able to compare it from year to year, it must be always either the first piss in the morning, or for the prostatic gentleman, the one at 3 a.m., 5 a.m. or 7 a.m. They'll all do. A progressive increase as a risk factor for vascular disease is as powerful as whether you do or don't smoke. You can't test for smoking at point of care. We don't have urinary cotinine levels at point of care, but you can test for urinary albumin creatinine in diabetic patients who have a 4 times higher rate of cardiovascular disease mortality and whose death from their first attack is as high as the rate of death from the second heart attack in non-diabetic patients. We could be doing this tomorrow. Stabilisation or decrease in that number is meaningful, and you can be very proud when you do it. You've achieved a surrogate endpoint for which you should pat yourself on the back and go home and have a whiskey. Abnormal results need a repeat test. See this Johnson thing for an explanation of that, but it does need a repeat test, so you're not going to do it once in a year in that first year when you find it abnormal. And you are expected to have 2 confirmed abnormal tests before doing it. So you may do 3 tests in the first year, but it's usually annual after that. It prevents macrovascular disease, it prevents death, and it prevents progression of renal disease. This is cost-effective medicine, and who gives a bugger if it's cost-neutral? Potassium and creatinine. Well, if you're going to try and treat people for renal disease, why don't we just measure that at point of care? Seems logical to me. Liver function tests. Steatosis hepatis, fatty liver, is now an epidemic, mainly in diabetic patients, but also in some well-cushioned non-diabetic patients. And this is now the commonest cause of cirrhosis in Australia. Australia is a heavy drinking nation, and we're worried about that, and we see that on current affairs every day, but nobody puts steatosis hepatis up there. We could be testing for liver function test and talking to the patients and embarking on a low fructose, low fat diet and so on. And ketones, there's a group of type 2 diabetes drugs called the SGLT2 inhibitors. They are fantastic. They improve glycemia, they avoid hypoglycemia, they reduce progression of renal disease, they reduce heart failure, and they are entering widespread use for very obvious reasons. They virtually market themselves. But they have one nasty habit, which is in patients who are on insulin, whether it's for type 2 or type 1, we aren't licensed to use them in type 1, but patients with a very poor pancreatic reserve can develop ketoacidosis during times of stress. These would include a major illness such as Professor Booy's influenza. It might be an anaesthetic or dental anaesthetic. It might be a bowel preparation for colonoscopy. It might be a coronary angiogram and so on. And so gastroenterologists, cardiologists, anaesthetists, GPs, emergency department doctors should really have the wherewithal for testing ketones. In fact, the same device that does a blood glucose level that's not reimbursed, but the strips are 6 times more expensive because they're not subsidised by the PBS. I don't think we'll get a reimbursement for that. If you want a reference, there's a lovely little audit from a South Australian group of 13 patients who developed ketoacidosis on arrival. So why test at point of care? Because it is likely to lead to a change diagnostic assessment and change management. I would add, in response to what Andrew and Roger have been saying, that may not be the right management, but that's a talk for another day. But it does produce that during the course of a single visit, and therefore it is more efficient for patients especially, but I believe for the health service on the whole. The MSACC application and the MSACC response have barely concentrated on this. It's understandable. The MSACC application did not come from clinicians. The MSACC response was about people who are desperately worried about whether it was cost neutral. Nor should we forget the traffic lights summary diagram of the NSACC report, the one that's 10 years old and 10 years and 9 months old. It was almost all green for the 2 tests I'd love to do at point of care, hemoglobin A1C and urine albumin creatinine. We've got anticoagulation over here, lipids here, and these 2 right-hand columns are hemoglobin A1C and microalbumin, and they keep on getting these glorious reports throughout this paper. A little bit of amber, but mainly green, except that pathology providers the results are less clear. I like that. And but mainly the results supported point of care testing, and that was 10 years and 9 months ago that they showed hemoglobin A1C and urine albumin creatinine are so accurate and so well done at point of care that they're easy to support. I thought I'd end on a miserable note. I like to inspire you when you go out to lunch. Practice incentive payments. To obtain these, GPs must show that their care plan patients, and they get about $120 for writing a care plan, have completed a cycle of care. They then get a strange calculated number that I can't understand. They get more dollars if they complete the cycle of care. And it depends how many patients in your practice have completed the cycle of care. It's not how each individual went, but how they went as a percentage of the practice. And it must include laboratory measurements, and the current minimum number of hemoglobin A1C tests is 1 per year. Now, unless a Medicare benefits number is attached to point of care testing, and I don't mind if it's $29 or $0, it's got to have a number. And it does have a number in Aboriginal health centres. The number is possible. But unless it's developed, there will be a perverse disincentive against doing hemoglobin A1C at point of care. Because Medicare has a Little Britain phenomenon, computer says no. And if they haven't received that item number from the lab to their computer and they haven't received the item number from the GP to their computer, the computer that puts the 2 together, which resides in Adelaide, says no. There's also a problem of bulk billing and equity of access in Medicare. If I were to adopt point of care testing for hemoglobin A1C because there was an adequate, perhaps slightly loss-making, but adequate reimbursement, I could bulk bill for the point of care test and I could bulk bill for the appointment for whoever deserved bulk billing. If I adopt it now and I charge Wilton Braund's fee, and I'm going to say I'm going to choose the fee that Sigma Pharmaceutical charge, which is $25. That's pharmacists. So I charge my own fee. It's now illegal for me to bulk bill the patient for the appointment. And when I say illegal, I'm talking about criminal charge, minimum $10,000 fine, reimbursement of all Medicare fees, and legal costs. And if the point of care MBS reimbursement is going to be inadequate, I will again be at risk of committing the same crime. And one of 2 things will give. Either people say, well, we're not taking up point of care, or they're going to say, well, I was fed up with bulk billing anyway, it's not enough, it's time I charge a gap fees to everybody. What is required to fix it? Shuttle diplomacy. Henry Kissinger got a Nobel Prize for this sort of thing. And who should be the diplomat and who is willing to be the diplomat is a very big question. I wonder if there's such a thing as a diabetic diplomatic politician who we could get on side. Thank you very much. Just a reminder to anybody who gave a talk up earlier, there are a couple of memory sticks lying around here.
Interesting and controversial all at the same time. Does anybody have a question they'd like to put to Wilton? Elaborate on this.
Last time I fooled you. I seemed like a duffer because I gave the wrong talk and realised it only halfway through. This time I've got you intimidated because I got the right talk and I sounded authoritative. Not really. It's about 3.5 minutes for a hemoglobin A1C. It's about the same thing albumin and creatinine. I'm pretty good at the patter. I can measure their blood pressure while I'm doing it. I can look at their feet for finger prick tests and so on. The way we had it set up originally was it was actually done by the reception staff as the patient arrived. Not one of them had nursing training. They were perfectly accurate. So you can do it either way, depending on your throughput. And compared with being on the phone to the bloody SA pathology, it's not
Excellent.
yes, ma'am.
Thanks for your talk. It's actually very informative.
Honorary member?
Pardon?
Honorary member?
It's really what we're trying to do at the moment, and is actually about identifying and building some evidence around actually what it does take to do point-of-care testing that's effective for patients in a timely manner. So really, really great. The frustration, about point-of-care testing being in Aboriginal community control sector for such a long time, and that it was allowable for community-controlled sector to diagnose using HbA1c, and not that they've actually had pushback with this application is just so frustrating.
It's probably very good for us to be able to, once in our life, envy Aborigines in Central Australia. It's very important that we do that. So if we take that advantage away from them, let's give them one other advantage we can be jealous of. I did it not start a political storm, although I am secretly grateful.
Well, we are over time now, so I'm going to thank you very much. No, that was well worth it. Thank you very much. Please join me in thanking Dr. Braund. And the unenviable position of the last session before lunch break, we're lucky enough to have Dr. Donna speaking with us, giving us an update on MPACC activities. Just quickly. No? All right. Beautiful. Please welcome Dr. Donna Rudd.
I'm sorry, but I can't help you with the MSACC or your money, but thank you so much for calling me young. I really appreciate that you've made my day. How do I make it come up on the screen? Well, as you said, unenviable position, lunch and talking about standards. So I really must apologise. As much as I can't help you with your payments and your Medicare payments, I will rush through this and get you out on time. I thought that I'd do this in a funny fashion because, let's face it, talking about standards is really boring. And so because... is that going to be all right? Oh, it's running off the screen, you won't be able to see it. I'm trying, challenging the technical department as well. Anyway, I thought that we'd bring this to you from Sesame Street. That's all right. That's all right. Let's see where we go from there. Okay, so, and today's session and presentation are brought to you by the letters N, P, A, and C. But seriously, folks, what is NPACC? Well, it's enshrined in our Constitution. It was a group of, a council brought together of very knowledgeable people in pathology to develop policies for accreditation within pathology and to maintain and introduce uniform standards for practice of pathology in Australia, and as also bring about coordinated legislation. There's an educational role and also an informative role for the minister. But today what I'm talking to you about are a provision of uniform standards for practice in pathology. So who is MPACC? Well, you can see there representatives from all the state and territory health departments, as well as some of the usual suspects from our professional bodies, the Royal College of Pathologists, AACB, thank you very much for having me here to speak, AIMS and of course ASM, and as well as some others, AMA, there's also Public Pathology Australia, Human Genetics Society, and we also have some consumers that come along from the Consumer Health Forum. Just recently, but the last strategic plan under the chair of Beverly Robotham has undertaken some really ambitious work looking at improving the oversight, the accreditation framework, developing a patient focus for the value of pathology and improving collaboration and transparency. And I'm hoping to sort of show some of that through the standards that we're developing here, because that's what I'm really here to talk to you about, is the standard setting and the drafting that we go through. So what do MPACC standards actually do? Well, like any standards in our society, they're absolutely everywhere. If you just think about this typical street scene, the cars you drive, the roads you drive on, even the restaurants you go to, all of it is underpinned by standards. And really, standards are invisible. When they're there and they're working, nobody notices. You don't notice that standards aren't there until they don't work. But I think you'll all agree with me that they are really important to ensure safety of products, services and systems. So very important and yet voluntary, and we do take care of that. So often you're going to need multiple layers of standards, and this is sort of evidenced in our food safety, which is something everybody can relate to. The food safety standards sort of intermingle with those of our primary producers, as well as our microbiologists as well. But what's pathology? Well, if we utilise this wonderful infographic from No Pathology, No Healthcare, pathology in Australia actually underpins 70% of medical treatment or clinical decisions. Nobody's really sure where that statistic came from, but it's very useful. There's about 500 million tests done, and there's 35,000 people employed by pathology, yet I'd ask you, it's invisible. And why is it invisible? Well, I really think it's invisible because we're really good at compliance with standards. And in our particular case, it's MPACC standards, but it's something we take on religiously within the lab. And we've been doing that for 40 odd years. And that really means that because we comply with these standards, we don't actually kill anyone, which is kind of handy. And if we do, because things do go wrong, what we do is investigate it, we report on it, and we make sure it doesn't happen again. And that's all part of a quality standard. And that's really why I think pathology is invisible. So now we're moving out of the lab. Point of care is out there. I think what you've seen this morning really demonstrates that. Our clients are desperately in need of it to improve their own work with our patients. We need to come into that space. That space is not necessarily going to be in the lab. Sometimes it is. We do use point of care in the lab, but most likely it's going to be in primary healthcare settings. So really, I like to think of this as really pathology outside of the lab. So why new and improved standards? Well, really, this is not new. AACB and the RCPA have been working in this space for a very long time, and that culminated in bringing out some guidelines in 2015. What we're really doing on the MPACC Standards Drafting Committee is taking these standards that were really written in laboratory speak. I hate to say this to my laboratory friends, but you do speak a different language to the rest of the world. We have a particular jargon. I work at a university. I watch the first week of my students in fourth year where a haematologist comes in and talks to them, or haematology scientist, and their eyes spin in their heads. We use different language. We need to sort of improve that. And so really, that's what we've been trying to do. Take those standards that we know work really, really well and write them in such a way that they can be applied in different situations outside of the laboratory. And of course, this is not new. This is something that's ongoing with lots and lots of different studies talking about readability and that health literacy, and so improving the language that we use. So who's on the team? And you shouldn't be able to see that, I've just checked. It's not me. There is people on this team that have been deeply involved and are absolute experts at delivering point of care. And they come from all states in Australia. And yes, there is people from the Royal College of GPs and emergency medicine specialists and people that work with point of care in a clinical sense. So it's a really good team. And what we're trying to do is really the aims of these standards are really to develop a quality framework in which point of care testing can be performed, and really what we want is to maintain and ensure that patient safety and manage the risks surrounding that so that you can have the same reliable results from your point of care test to make those clinical decisions, as we've seen through all the presentations this morning, how important it is to make those clinical decisions and have reliable results to do that. But we'd also like to provide guidance to any facility who intends to implement this technology, and really having these standards is about being able to achieve the same quality that you know and are familiar with from the traditional pathology laboratories. Some of the statements, as a clinical biochemist person, some of the statements that people have made about the reliability of tests has really made me really realise how important or how well the laboratory's hidden all of our flaws behind a laboratory wall and validation through scientific means. So I think we have to build that in. So, of course, we need a scope. These are just minimum requirements. They're going to describe just the key steps that you need to undertake to bring about a safe and quality assured point of care testing system. And we don't really want to tell you how to run those tests or when to run those tests or how to train your people. Really, these are just the steps you need to take. Of course, we'll need some definitions, and you can see there that point of care testing is really that's performed in close proximity to the patient by a healthcare worker. So really, by a point of care testing operator, that can be anybody who's trained appropriately and assessed by a recognised training program. A point of care manager needs to be a person who takes responsibility for that point of care testing. Of course, we're about patient safety. That's MPACC's goal, has been through risk management. And one of the things that comes down to all the time is this governance and management. So in having a section on governance and management, We're really asking that there be somebody with an appropriate qualification and scope of practice who is clearly identifiable as the person who has the responsibility for developing this management system. That might not be the person who's actually running the test day to day, but they are ensuring that there's policy setting, that there's an appropriate scope of practice, that the tests are used in an appropriate fashion, that there is appropriate education and training, documentation and review, and those results are used in an appropriate way. Of course, that's going to come through a data management system, which really just comes down to any quality management system. And if you have a look at some of the list there, you can see that it's just about a governance framework, it's about policies and procedures, it's about the location and environment, it's about sample prep, it's about test procedures, but of course that's all very long and wordy and very directed. So we've tucked that in the back into an appendix. So for those of you, there is, thou shalt in the beginning, but for people who are more interested in the implementation, as in the AACB's implementation guideline, there is actually directed use and examples in an appendix at the back. And really what this is about stopping the blame game when something goes wrong, because everything is fine, and everybody who stood up here today has talked about how well this point of care went in this particular case and that particular case. But I can equally give you some examples, and I will, where it doesn't necessarily work. And we can't, having an appropriate governance and management system documented and whose responsibility it is, allows us and stops us from having to go through the blame game. Of course, training and competency, numerous studies have shown that this is the link. This particular study, and this is just one of many, looked at the number of errors that come up when compared to a normal laboratory in an accreditation framework, and you can see there point of care testing wins, but that's not really surprising, I guess, when you apply laboratory speak onto people who don't normally work in a laboratory. So when you actually drill down to find out what are really the underpinning causes of that, you see that really it goes to that training and ongoing competency. And I'm wondering in this particular space with the training and the competency whether these people suggested that maybe you have an external quality assurance program or some sort of external oversight to help with ongoing competencies. And I think that's been spoken about today as well. Of course, pre-analytical and analytical and post-analytical considerations. Anybody who's done anything with lab, we'd like to divide our errors up into these places. The thing is with point of care testing that most of those analytical things are taken care of by the analyzer. The point of care testing device providers have put a lot of energy into making these things really user-friendly and workable outside of the laboratory. So really for us, and with a patient safety focus and risk management in our heads, really pre-analytical and post-analytical are going to be where it's at. And of course, pre-analytical is anything that happens before you get to the test. So that's making sure you've got the right patient, making sure that you prepared that patient appropriately, making sure you collect the correct sample, making sure the result is correct, and then recording that and reporting that in an appropriate time frame. The analytical, as I said, largely dealt with by the analyzer itself. But these things, the simplicity of these things really belies their complexity in terms of the biochemistry and the engineering that goes behind it. It's actually quite remarkable. Here's just a normal glucose or glucometer. And here you can see down the bottom, you've got your red cells, your white cells, and some protein. This is the actual glucose in that messy sample that's coming up here. And remember, this is just a finger prick, just one drop, not the whole patient's blood. We put that up against a test strip, which has some sort of outer membrane that allows these things to compete, and hopefully it's the glucose that wins. It gets through to yet another layer where a reagent is, and then there's a reaction. the product of that reaction has to get through another layer and then come to an electrode where there's actually a production of electrons which we then measure. It's really simple, huh? No. And there's lots and lots of confounders. And this is the simplest of our testing that we all agreed is perfectly fine out there. So there's lots of confounders. Some of them are to do with the physiology of the patient. Some of them are to do with the sample. And some of them are to do with drugs. So it's not as simple as we'd like it to be. But, of course, the analysers are terrific. If you look at their inbuilt QA and QC systems, they test at every single point, and they'll just give you a failed message if everything's not right, if the pH is not right, if the temperature's not right, if there's something going on that could confound that result, it will just give you an error message. But that is really terrific, and the manufacturers have really stepped up there. But is that all we need to do to ensure our patient safety and to minimise the risk to our patient? So probably the thing that everybody's really complaining about is this cost of external quality control. And that worries me to a certain extent because I feel that this is really where the patient safety stuff is going to come in, this opportunity to educate our users. And so I think that EQA is probably going to be more about education than ensuring quality, but I still think it's necessary and we have to think about how that can be delivered. So post-analytical is really an interesting space, and I didn't want to just talk at you, I wanted to share some experiences. Look, I no longer work in a lab, I work in an educational institution. I deal with students most of the time, but I do have some ongoing research with the hospital. And so what I've sort of seen when I go out and talk to users is that often point of care gets used off licence. Well, what does that mean? You know, you've got the test in my rooms, and so what if it's somebody's synovial fluid? Isn't it just the same? and probably yes, but you know, these things are unproven and we like evidence-based. And one of the things that's become really popular, because I've currently got an NH and MRC funded grant working with the NICU unit at the Townsville Hospital, and my friends there are really worried about this new phenomenon. It's called delayed cord clamping. Of course, they should be really ecstatic and excited because really delayed cord clamping is eating a bit for little tiny brand new babies, particularly very preterm babies, where it's here shown to, you know, reduce intraventricular hemorrhage and late onset sepsis. And really, clinical trials have shown that delayed cord clamping in very low birth weight infants actually reduces the amount of transfusions those babies have to have later. So it's a no-brainer. And of course, if anybody's ever worked with nurses or midwives, they're very excited about these new things. And if it's good for the preterms, it'll be good for the terms, won't it? Well, what they've noticed is, of course, delayed cord clamping happens on everybody, and probably now the patients are asking for it. So what they've found is when they look at the number of babies readmitted, term babies readmitted for phototherapy, having a really high bilirubin, you can see that there's been this exponential rise in the number. And these babies are having their bilirubin measured on a point-of-care testing analyser that the NICU's had for years and years and years and years. We don't try and interfere with their measurements. They've got a very precious sample. It's tiny. Those babies don't have very much blood. You can only take a certain percentage of it to do your testing on. So we leave that in their hands. They're very good at collecting those samples. They have specific devices. Perhaps there may be some training around you must mix the sample so that it doesn't clot in the machine. We also teach them about the effects of hemolysis, which is hidden there by something I didn't put a specific animation on, sorry about that. But we've known about hemolysis interference with our traditional assays in the lab. And of course we can train people, and that's been demonstrated for a long time. People are trained. But the thing with measuring bilirubin on this analyser is it's a very different test from the one that's done in the lab, and hemolysis doesn't necessarily interfere because it's a direct spectrophotometric method. So there's other interference there. Why is this important? Well, it's important in these babies because hematocrit increases from the time you're born. And when you delay the cord clamping, this hematocrit goes up really, really high. In fact, they get polycythemia. And that polycythemia is actually interfering with their bilirubin measurements, causing them to readmit these babies. When they draw blood and send it down to the lab, they get a lower result that said, you shouldn't have admitted this baby. So it's really interesting. We don't know whether it's the background of this analyzer or whether it's the polycythemia or whether it's the lab test, but we're currently rolling out a trial at the moment to have a look at that. Another aspect is something you've probably never thought about, but I get from time to time to work with these guys. There is some benefits for living up in a tropical town. And the vets, let me tell you, they're all over this point of care testing stuff. Don't you worry, don't you worry. They tell me all the time how easy it is, and I watch horrified from the background of a research study thinking, well, there goes a result we won't be able to use. But anyway, you keep pushing those red cells through that syringe and needle. But we collect from the dorsal sinus, so there is some physiological stuff going on there with the turtles to begin with, but they love their eye stats. And they brought me in way too late on this study. They'd already been looking at metabolic bone disease in this captured turtle colony that we had, and they sort of sent them to me. And here, in the orange and the blue, these are 12 different turtles. Here's their bicarb results, or the total CO2 results measured on an eye stat up the top there. Overlaid on that is their pH, which you can see sort of mimics that a little bit. But when I spun the plasma down and ran the samples on my analyzer, I actually got bicarbs that actually fitted with what I was seeing, because I was saying these guys have got a metabolic alkalosis. In fact, they were trying to talk to me about alkaline tides and all sorts of things with these turtles and reptiles and all sorts of things. And I just said, no, the Henderson-Hasselbalch equation doesn't lie. There's something wrong with those results. And lo and behold, if temperature doesn't make a difference. And in the background, the iStat does this wonderful temperature correction. These turtles, that's all right for someone who's a patient who might be at 36 degrees, but not so much for the turtles at 25 degrees. And you actually do need to do some manual. So the reality is that these guys are very different from these guys. But again, the clinicians had not thought about this. And I felt really embarrassed a little bit because, you know, I'm just the lab tech and I'm the idiot in the corner, and what would I know about anything? But I had to then point out to them that this could be a problem. So one of my biggest worries is that if you, go without linking back in with the scientists in the lab, they're going to miss out on the benefits of a lot of these studies. I'm finishing now, so you can go and get some lunch. Awesome. So we've added some appendices at the back, and you'll recognise some of them as they whiz past your eyes. These are just really to make things more simplified, again, back into plain English. So you'll see this in the implementation guide. So there's a little bit of cross-fertilisation there. Can't imagine how that sort of incestuous stuff happens, but it's good that it does. There's also some descriptions of these common pre-analytical stuff. So it's potentially stuff that you haven't noticed before, but being in a lab and working with that for 40 odd years, we're very familiar with it and we look out for it all the time. So if we can share some of those stories, that's an educational thing. And also those steps to build your quality framework. Anyway, back to the Sesame Street theme. I'd like to thank you very much, because MPACC really wants to come out of the lab and provide some advice for assuring pathology is safe and risk-free, I guess, and provide this safety network. I guess you just need to watch this space, and it should be much shorter than 10 years, I hope. Thank you.
Do we have any questions for Dr. Rudd? Yeah, Mark.
How much shorter than 10 years?
Much less. A 10? Definitely a 10.
The other thing, what type of general practitioners will use their 20 care guideline over the last year?
Listen, we love
Thanks. That was a perfect answer to a great question because we're all keenly watching this space. So please join me in thanking Dr. Rudd. Thank you so much for a great presentation and the Sesame Street lesson.